Mute ಆಯ್ತು ನೋಡ್ರಿ.
Your voice is not audible, sir.
About living a healthy life with a healthy heart, about using your influence to set an example for your loved ones, and about the compassion to look beyond just yourself and think about the ways to support the most vulnerable society. The virtual meetings have now become the norm, although they will never replace the face-to-face contact. They have showed us to continue building the engagement with the colleagues and the friends all around the country and abroad. I am able to see my friend Dr. Manoria today after a very long time, and I am also happy my student Dr. Vivek is with us, Dr. Biradar, Dr. Murugesh, Dr. Alsetti. They have taken a lot of pains to organize this particular program, and I have great pleasure in this program and also wishing the function all success. Thank you.
Thank you, sir. Now we move on to scientific session. I request Dr. Ajit Mullah sir to deliver his talk on pharmacoinvasive approach in management of STEMI. Request Dr. Irana Hirapur, cardiologist Gulbarga, to introduce the speaker and chair the session. I
Good evening,
request all
sir.
the questions to be typed in the chat box and at the end of the panel discussion.
Good evening, sir. Thanks for giving me the opportunity to talk something great about this great person. Dr. Mullasiri Ajit Sankar Das is the Director of Cardiology, Institute of Cardiovascular Diseases, Madras Medical Mission, Chennai. Sir has completed his MBBS, MD General Medicine, DM Cardiology from Grant Medical College, Mumbai, Bombay. Diploma from DNB from Bombay, from the same Grant Medical College. He is a fellow interventional cardiologist, the Principal Charles Hospital, Brisbane, Australia. Sir has got awards, innumerable publications. He has got multiple international awards, national awards, multiple publications. He has given orations. He has written multiple books. To talk about his achievements, when I got that CV of sir, it is 43 pages. So in short, I would like to tell that we are very grateful to hear such a great person who is speaking on the topic pharmacoinvasive therapy in STEMI, rational timings and outcomes, which is more so important in present day in the era of COVID. Over to you, sir.
Thank you very much, and I'd like to thank Dr. Sangram for inviting me. I'm sorry I couldn't physically ever come to Gulbarga on his invitation, but I thought this was a good opportunity to make amends for the past. So my topic today is pharmacoinvasive therapy in STEMI, the rationale, timing and outcome, and why this is the only way we can treat STEMI in this country in a good way. So if you look at this slide, I think would summarize my entire lecture.
To be a movement. Why minimally invasive surgery? We all know that cosmesis, if my patient is a young woman, I will bend backward, I will do some compromises, but I will give her a minimally invasive surgery. And I'll try and see that my scar doesn't peep through her blouse line. And also it is hidden in her bikini. It gives you less pain. Has got a less blood loss. It gives you a chance to avoid sternotomy. So very old, osteoporotic, poor healing, coagulation problem patients, this is a godsend. Also, it gives you an overall reduced mobility and fast tracking. If my patient has got some important job, like he's in salesman, there is no much family support, he has to go back to his earning faster, I may use this. But what is happening is, one of the most indication that emerged was market pressures. Commonest real world indication. And we should be wary of that. There are different approaches, mini or hemi sternotomy. I have given it up because this is a natak. If you do a full sternotomy or a half sternotomy, the blood loss, the trauma, the pain is the same. But because we do a T or J, the pain is actually more, and sometimes we could have healing problems. Mini thoracotomy, where you spare the sternum, is a good ideal way. Then now the para-areolar incision has come, where this is truly endoscopic vision and completely truly least invasive procedure. For mitral valve, ASD, PAPVD, this can be very easily used, but this requires a steep learning curve. We have started doing this subxipoid procedure for Lima to LAD or gastropolic artery to the RCA since last 3 years, and we have done quite a few of cases. And there, because it's on the abdomen, the chest is not touched at all, the painlessness is quite superlative. Recovery is very rapid. The hybrid, we are far less cynical now, and this is a good idea for people who are poor healers, who have bad comorbidities, who have advanced age. If they have a bad triple ulcer disease, and I can give a Lima to LAD and allow my cardiologist to do the stents elsewhere, even later the stents get blocked. Today, medical management is so beautiful that we can manage a good longevity and quality of life for these patients. Then also in aortic disease, aorta diseases, this has come as a boon, especially arch aneurysms and emergencies. The closed chest video endoscopically, vision guided 3D endoscopic, robotic telemanipulation, etc. is another option. But in cardiac, it is little far-fetched, though some people are doing it. It's more for brand value. MICS of cardiac valves, MICS for CABG, mid-cap is for minimally invasive direct coronary artery bypass through mini thoracotomy, and TCAB is for robotic assisted. MICS for congenital heart disease in grown-up children. In very small children, it becomes a circus. MICS for atrial fibrillation, but in the era of interventions and good ablations, when you cannot do the real biatrial class 4 maze, this also, and also in India, where we are really not operating on patients who are standalone AF, and we are mostly adding it as an add-on for mitral valve, one has to have a hard look at really, do we do this, or what should be my priority? Because the patient has to take the center stage of planning and not my brand value. Any center which is starting, there is a learning curve, and there's a significant learning curve, but it should not be at the cost of patient. So we start with a direct vision surgery where we're not used to be looking at the screen and operating here. We take some time to develop this hand and eye coordination. And we can learn a lot from the laparoscopy surgeon about that. But in the initial stages, the incision is 12 centimeters. Then we go on to learning how not to look down, but look only there and operate. Then the incision can come down. And then that can be the truly minimally invasive surgery where it is bloodless, pain is very less, and the recovery is very rapid. And that is minimally invasive surgery. It is more costly because the instruments are expensive and a lot of things, the setup has to be complete, and no cost cuttings and no corner cuttings. The level 3 is video directed, robot assisted. Today, mitral valve repair and some of the Lima LAD coronary bypass surgeries and taking down both the IMAs for doing a mini thoracotomy, multi-vessel coronary artery disease. This can be indications, but much of it is far stretched. It is just for breast beating and me too. Almost all our hospitals, big hospitals, have robot, but none of the surgeons are really jumping on it because it is really not a patient-friendly procedure. And we think honestly that the time has not yet come and it's not in the patient's interest. All these equipments are important. Unless you have a full proper setup and correct instruments, trying to do a minimally invasive surgery and jumping at it is at the patient cost. And if you have to all this full setup, your surgery cost is going to be 10 to 20% more, and that has to be explained, and that cannot be compromised. MICS through mini sternotomy. All these things can be done, and I had a couple of junior partners because of whom we did almost a few thousand cases of multi-vessel bypass surgeries through mini sternotomies. But what happens is this gives a lot of pain. It's a cumbersome surgery, and we left it off now because it's a bit of a natak. And anything to do with this mini sternotomy business, I think is not ideal, and it's a story of the past. We did it in the growing up stages. This lady that you see is a Gulbarga patient. Those days, we learned in 1996 from Cleveland Clinic how to do it through the mini sternotomy. And Cleveland Clinic did it in the beginning of 1996. Somewhere in the later half of 1996, we also started. And this was a poor man's minimally invasive surgery through mini sternotomy. We do it just like a full sternotomy. You can see that. And you can see towards the end of the video, I can see the mitral valve so beautifully, just like the open sternotomy. And I can do my minimally invasive through mini sternotomy repairs very dynamically. My only problem is I can't put the if I'm doing it awake, I cannot do a TE. But if I'm doing the endotracheal tube, then I can do a TE and I can do a very classy mitral valve repair. Almost all the patients that we operate now are intended to be repaired. So if you are doing a mini thoracotomy, see the mitral valve, so beautiful. If I'm doing a mitral valve surgery, I must ask myself that can I have the same confidence index of doing that many number of patients minimally invasive repair and not jump onto replacement, then I should do a mini thoracotomy or the periolar or areolar incision. Total endoscopic through mini thoracotomy, we can do a mitral valve nowadays very well. But only question is that I must be cocksure that I can do my mitral repair through the mini thoracotomy and endoscopy as good as my open sternotomy, and the same percentage of patients will receive my mitral repair. If not, don't bother. That cosmesis, especially for a male patient full of hairs, is not required. The pain is really not so great in open sternotomies. If you don't open too much, don't crack the ribs, not a problem. But if you are sure your learning curve is complete, then stick to mini thoracotomy. It's a good operation. So when you are referring a patient, if there is a patient who is for repair, search for a good minimally invasive surgeon who is doing repair left and right through mini thoracotomy. Otherwise, stick to a surgeon who is a good classic repair surgeon and send the patient to him. Unsuitable candidates are highly calcified mitral annulus, severe pulmonary hypertension, significant untreated coronary disease, severe peripheral atherosclerosis, and prior right chest surgery where there's too much of adhesions. Don't do that. Don't even tell the patient's family, because the kids nowadays read the internet and go on pressurizing the elders for this surgery, and the surgeons will oblige. Not required to play their circus. Suitable candidates are patients with primary valve disease, operative mitral valve patients, because it's so beautiful not to do any lysis of the adhesions and waste time there. And the old valve is hanging like a beehive from the roof, and it's very easy. Bileaflet and anterior leaflet disease, I get a superlative exposure and I can do a good repair. Combined tricuspid and mitral operations, mild annular calcifications, obese and large patients where full sternotomy can be morbid, and this can be a godsend. Elderly patients where we don't want to cut the sternum. But I must be a good repair surgeon through mini thoracotomy. That is the bottom line. We are very happy. I think today ASD, PAPBD, mitral surgery, aortic valve surgery, LA-myxoma, tricuspid surgery, this can be a gold standard. The only debatable will be multivessel coronary bypass surgery. I think it is a gimmickry if we are doing even the posterior grafts or doing 4 or 5 grafts, which is very common because most of the patients who are low-hanging fruit for angioplasty, surgery would be with multiple grafts. AVR, now the mini sternotomy days of AVR, everybody should do mini sternotomy. Again, I said it is a matter, and we have all quickly moved on to mini thoracotomy. I have 4 junior partners. Everybody is good with mini thoracotomy AVR and mini thoracotomy mitral repair or mitral replacement and all other indications that I told you. This is a good operation. And only thing is there are a lot of people who are advocating to put a sutureless valve. Sutureless valve is nothing but the TAVI valve, transcatheter valve, which is put through an open mini thoracotomy. And so if there are some question marks on TAVI, there are also question marks on a sutureless valve. So if I'm going to put a nice Evolus or trifecta new generation pericardial valve, taking all the cares of no touch technique, nicely replaced, and I have a chance that this patient may have a longevity of the prosthesis going up to right up to 20 years, sometimes more, with the new generation valves. So I have to be very careful whether I really give a sutureless valve only for the elderly patients who have a lot of comorbidities and I want to do a quick surgery. There are surgeons, even we have been doing Bentals through mini thoracotomy or mini sternotomy. But very straightforward, plum, low-hanging fruit cases, it's okay. Otherwise, there's no point. But a lot of people are doing it, and it's mostly a kind of breastfeeding and brand building exercise. Look at this. This is a friend of mine. This is not my case. Hokum surgery, all that chunk of muscle is removed through a mini thoracotomy by cutting the anterior mitral leaflet at his base, doing that resection, and then suturing back the anterior mitral leaflet. I am not really amused by all this. And there's unnecessarily flirting with that virgin, pristine mitral valve. And we can do this a good quality job from a full stenotomy. And I would rather not err on cosmesis. If it was a woman and much youngish, I will put my incision much below and somehow manage full stenotomy, and I can do a very good quality Hokum surgery. We are kind of a bit of a specialist of Hokum surgery, and we tried this, but I think this Me Too business is dangerous and one should not fall for it. Neither you should fall for it while you are referring cases. Everybody, I will give you bilateral IMA. Don't fall for it. Conduit selection for a bypass surgery is a 33 marks essay question MCH. Otherwise, everybody would have done that. Similar way, minimally invasive surgery. Then the AF. Most of this AF becomes only a pulmonary vein isolation. That my cardiologist can do. And if it's a standalone AF, chronic AF, I would rather refer to my good electrophysiologist. But if I'm doing a mitral surgery, then I would insist that I will do a good class 4 biatrial maze, and I will not do any compromise, and all those cryos I will put inside. And if I cannot do by minimally invasive, so be it. And most of the times I cannot do, and I will not advise. But I must do the maze. In the long term, maze is not treated, and you have done a good mitral job and given a good longevity. That also is a bit of a not a very good thing to do. MICS through mini thoracotomy, you can do mitral valve replacement, mitral valve repair. maze I already explained. AVR, sometimes DVR, definitely tricuspid surgery. ASD, PAPVD, cardiac tumors, especially only benign tumors, mainly myxomas. And CABG, multi-vessel, I have my reservations, but definitely the anterior vessels, all of them, we are all erring in doing minimally invasive. All my partners except one, the juniors, are very well trained because for a long time we have been doing this minimally invasive bypass surgery, and everybody is very well exposed, lubricated. All mistakes have happened in the past, but we have realized that there is no point in trying to stretch and doing everybody this way. That is a brand loyalty, and that is fanaticism, like a religious fanaticism. So the posterior grafts, there is no point. So one important principle one must understand when you are sending a patient for bypass surgery, you must insist and ask, and you must also expect that do not compromise on the basic premises, completeness of revascularization and neatness of anastomosis. Then do whatever you want. But give me complete revascularization, give me nice looking grafts if I do an angiogram. McKean is a guy who is the top authority and a top surgeon doing the multi-vessel minimally invasive cardiac coronary bypass surgery like this, large numbers. I happened to have a drink with him in a bar, and we were chatting for a long time, about a couple of years back. And I asked, this guy is a very honest guy. I said, you are in New York and nobody does this in America, and you are doing, everybody come what may, minimally invasive, why are you doing this? He said, Vivek, you must understand that I ended up in a private practice in New York. It's a deadly place, and the practice is very intense, the competition. I had to do something different, and so I started doing it, and I survived, and my practice is good. That is the answer. No, I am going to do this if my patient is going to benefit, and not for myself. I realized that in the first 5 years of my being a monkey. So that is the message that I want to give, that front grafts, good. All graft, 4 graft, 5 graft, I am not impressed, and I will not vote for it. And if you look at India, there are so many skilled, solid surgeons. They are not opting to do this. And that's the reason. For surgical honesty. In surgery, there is ethics and there is morality. Ethics would say it is our morality will not allow you to do that. Now, this is something new we started. I told you that abdominal CABG. Epigastrium, like this, there is a free space. I can lift the sternum and I can see the lima and take it down with the endoscope, and I can very easily see the LED in front of me and do that. If a patient requires a PDA graft, I can very easily in front of me, there's a peritoneum, I can pick up the gastroepiploic artery using Halbonic and look at this log which was done after many years. There is a beautiful patent graft there. So next is this robotically assisted surgery. I will not waste my time on it. There are 4 or 5 surgeons in India who are doing it now. They all are my good friends, but I'm not amused. I don't think it's a patient-friendly exercise. A, costly, B, cumbersome, accidents can be terrifying. And I told you that if I'm doing CABG, I will not really give him the deal of completeness of reversibleness of anastomosis. Good for mitral repair, but can I do it? Am I good? Then I will opt for it. ASD, why? I can do perioral incision, small thoracotomy, and I can do it so fast, easy. The junior most person in my team can do it. So I'll not use all this. Then for the pacemaker lead, again, I can do through a mini thoracotomy, and that's not a big deal. I can even do an abdominal. So I am today not really kicked by it. Let us wait and watch, because there are new product coming. But this promise has been for too long. It hasn't really fruitified. We will wait and watch. So it is here to come, but it is still, we are not there yet. The minimally invasive hybrid revolution, I am by that, both for coronary and also aorta. This case, I keep on telling this case again and again. This was a 72 or 74 years old physician from Mysore, 12 of them a Bental with triple vessel bypass surgery using a bilateral IMA. And now this guy came, section and a small leak and a 5-gram hemoglobin. So his wife also is a physician. She drove him from Mysore, Birmingham Road by night. In the night, we all gathered. Gopi, Keshav, they all gathered. And we did a mini sternotomy and did a arch vessel exclusion, the arch bypass, so that from the graft to the arch vessels, we did the bypass. We clipped all the arch vessels and we gave it over to the cardiologist. We wheeled the patient to the cath lab, and then they put 2 separate stent grafts. One was in the arch, then leaving some space for the subclavian artery from where the lima graft arose, and another graft. And that guy did so beautifully well. We replaced the blood, brought his hemoglobin to 10 grams, and he came out like a. Then I told you about the hybrid coronary. That is also a good idea if the patient are really frail, old, not very fit for open surgeries. This is a good idea. The hybrid operating suite, which has 3D endoscopes, cath labs, robots, is it worth? It's so expensive. I don't know. We have not bought it. I did not vote to buy that. I voted for robot. My urologist and my oncologist surgeons and my are doing full use of my robot. Every day we are doing at least 3 surgeries robotics. In Bangalore, whole of Bangalore, I think every day almost about a dozen or more than a dozen robotic operations happen. But cardiac, except one surgeon, nobody touching it, because we think it is today still a natak. So thank you very much. This was a bird's eye view about hype versus reality. This is a good new form of surgery. It has matured, a lot of equipmentation, the visualizations and instruments have come. It has become much easy, much reproducible. There are a lot of training modules and a lot of programs, and every surgeon is now doing it, but one has to be careful and refer a patient. Don't refer to me too. Refer with proper indications and sober down your expectation first, and control the young relatives also of the patient. Thank you.
Thank you very much, thank you very much, Dr. Vivek. Your presentation was extremely good, and it was full of skills, and it showed your experience and lot of expertise. I really thank you. Congratulations. Over to Sangram.
Thank you, Dr. Vivek Johri, sir. Now we move on to our next speaker, Dr. C. Narasimhan, to deliver his talk on the importance of clinical evaluation of heart failure. I request Dr. Murugesh to introduce the speaker and chair the session.
Good evening, everyone. It's my pleasure to introduce the next speaker. This is the third talk in today's webinar. And Dr. C. Narasimhan is the Chief Cardiologist and Electrophysiologist, Director of EP Lab, AIG Hospital, Hyderabad. Today is going to talk on a different cup of tea, that is a clinical importance of clinical evaluation of heart failure, the basic science I can tell you, what we teach the postgraduates, or we all should know it. So over to Dr. C. Narasimhan for the next.
Thank you very much, Dr. Dr. Sangaram. I want to go back to basics. Over a period of time, we have been kind of hearing about devices, drugs for heart failure. Forgetting, like Dr. Javli was saying, the basic skills why we are there is to do the right thing for the patient. And in all the guidelines that the Western guidelines come up with, it is almost considered that diagnosis of a clinical entity, tailoring the treatment is a very simple phenomenon, and everyone falls into a bucket. We'll show some case examples why not so, and the importance of clinical evaluation in the patient with heart failure. First of all, it may look too redundant, but we have seen this exception. I'll show you example. Is this truly all the symptom of patient? Is it related to heart failure? If it is heart failure, does this patient have low ejection fraction, preserved ejection fraction? It's extremely important to make this distinction because several therapies like sacubitril/valsartan, vasodilators do not work in HFpEF. And one area where there's a gray zone now we have realized is heart failure with mid-range ejection fraction. And third is to understand whether there is underlying substrate of ischemic heart failure versus non-ischemic heart failure. Because if there is ischemic heart failure, especially recent onset, and the volumes are not very gross, you need to strongly consider revascularization if the patient has viable myocardium. Non-ischemic cardiomyopathy, we have a very low threshold for imaging, advanced imaging to risk stratify these patients. Now, as I said before, at least once in 2 or 3 months, we get a person who has gone to a gastroenterologist because of transaminitis, or he has had abdominal fullness and he has presented with nausea, vomiting, anorexia, even endoscopy is done, and then they get referred for heart failure because the endoscopy, they realize there is splanchnic congestion or hepatic veins are dilated, so on and so forth. So please remember, whenever you have a person with postprandial fullness, abdominal discomfort, and this person has a leg edema, unless proven otherwise, you need to look carefully for JVP. And if JVP is elevated, it's not hepatic cause, it is cardiac. But the caveat is some these patients, especially with near normal cardiac size, so that you don't feel that the JVP is pulsating, that's why it's missed out. Classic example is constructive pericarditis. The other conditions are patients, they don't come in compartments. A smoker who has got coronary disease, who has got heart failure, he may have an element of COPD, right heart failure, and he may have left heart failure also. Interstitial lung disease. Some patients with CKD have a disproportionate salt and water retention. It depends on the GFR and the phenotype of CKD, where the patients have a disproportionate avid salt and water retention, and they present like a heart failure. One of the other common things is in elderly persons who are ventilated with mild to moderate LV dysfunction. And you keep on treating them as aspiration pneumonia, but with increasing FiO2 and PEEP is being required, and you realize that there is coincidental heart failure. Elderly people do not complain much of dyspnea, and they may present with nocturnal cough and cognitive dysfunction and a confusional state rather than overt dyspnea. This is very common in elderly phenotypes of heart failure. Now, why is this clinical evaluation? Because the treatment varies, process is variable. For example, you talk about beta blockers, sacubitril/valsartan, SGLT2 inhibitors. we are kind of flooded with data regarding this. For example, if you have a person with moderate to severe aortic regurgitation and he has heart failure, you should not decrease the heart rate. In diastole, the longer the duration of diastole, longer the regurgitant fraction, and the person will worsen. On the other hand, if you have a person with severe MR, you abruptly lower the heart rate, they don't tolerate it. So you need to tailor the treatment according to the needs of the patient. And there is a potential for completely reversing the illness if you understand what the mechanism of heart failure is and helps you to tailor the treatment. So with this background, I'll just give you a couple of case examples. In the interest of time, there are several case examples. I've just chosen a few which are of importance. So first is a young boy who is actually from a Gulf country, slated to go to Germany for a transplant. But because of visa issues, he ended up here with this kind of an ECG. The heart rate is not impressive. All that you see is a very abnormal P wave, and the heart rate is going around 140, 150. But the problem is that this patient has this rhythm day in and day out for the last 5 or 6 months and came with a cardiomegaly. Now, please remember, when you have an atrial tachycardia and severe biventricular dysfunction, you give a dobutamine that will accelerate the AV nodal conduction. And the person happened, they started on dobutamine, and patient developed a VF the same night, had to be converted, defibrillated, and he was ventilated. And then we realized it was a simple focus in the crista, which was successfully ablated, and you find that over a period of time, the heart size comes down. Now, is this an isolated example? No. You go back to the original Boston Children's Hospital series. Among children listed for transplant, they had anywhere from about 10% of them had persistent atrial tachycardia as the mechanism of heart failure. Now, this has been well studied from our European colleagues, where simple common atrial fibrillation, where you present with chronic atrial fibrillation and LV systolic dysfunction, if you restore sinus rhythm, their ejection fraction improves and the LV volumes come down, and they have a significant improvement. What has changed the paradigm shift over the last couple of years is the consistency of results, especially because the contact force we are able to measure, and we are able to have a success rate of close to about 90% in these patients. This has translated into approximately 50% of mortality reduction. This looks too good to be true. Nevertheless, you need to take it with a pinch of salt. A subset of patients with biventricular dysfunction, severe MRTR due to atrial fibrillation, if you can successfully achieve sinus rhythm, you can maintain and reverse the progression of heart failure in a significant percentage of them. It doesn't have to be always an ablation. You can just think of loading them with antiarrhythmic therapy and cardioverting and seeing whether this patient reverses or not. If the patient achieves a near normal sinus rhythm, then you can consider a more definitive therapy. And this has translated in terms of improvement in survival and reduction in heart failure hospitalization. Over a period of 5 years, there is a reduction in mortality. Now, this is what for physicians I would like you to emphasize. Common clinical example is you see a patient with atrial fibrillation and rapid ventricular response. Patient, you had started him on amiodarone, beta blocker, digoxin. He's doing well for a couple of months, and then he comes back saying with a rapid ventricular rate, decompensation. We tend to increase the dosage of the drug. Please remember, in patients with heart failure, the margin of safety between therapeutic efficacy and toxicity is very narrow, and you cannot assess at one point in time. Say the patient converts at midnight to sinus rhythm, because of you have given so much of drug, they can develop long pauses, and that can trigger a torsades, which can present as a sudden cardiac death. You don't realize the amiodarone, which you gave with a fond hope of controlling the problem, was responsible for the sudden cardiac death in certain cases. So the other common causes that you need to look at is hypertensive heart failure. A subset of patients with hypertension who develop severe LVH, they have increased mineralocorticoid receptor activity, and they have avid salt and water retention. They can present as this is an easily treatable cause of heart failure. Aortic stenosis, of course, I'm sure all of you would have heard several CMEs following this TAVR thing about detecting aortic stenosis. But one of the common things is in any patient, adult patient with either diabetes, hypertension, or even in the absence of it, if you find that there is a loss of R wave, there is a Q wave or STT changes on the ECG, you should rule out coronary artery disease as the cause of reversible heart failure. And tachycardiomyopathy, we forget, common cause of tachycardiomyopathy is not this atrial tachycardia, but atrial fibrillation and flutter, which is eminently amenable for curative therapy nowadays, and you can achieve sinus rhythm in a vast majority of patients. Increasingly, we find that obstructive sleep apnea may not be the direct cause of heart failure, but can contribute to the morbidity. And if you correct this, there is a significant improvement. One kind of misconception among physicians is that the patient need to be for them to develop obstructive sleep apnea. That is not true. You can have a lean phenotype where there is a loss of muscle tone in the pharyngeal muscles. And these are patients who are malnourished because of heart failure. They tend to have apneas during sleep. And once you correct this, there is a significant improvement in the syndrome of heart failure. They tend to have disproportionate right heart failure and pulmonary hypertension. For the degree of left heart failure, that should make you suspect. Second thing is, if these patients have nocturnal muscle cramps, periodic limb movement, episodes of atrial fibrillation, and pauses during night, those things should make you suspect that you have an obstructive sleep apnea, which is contributing to the problem. Of course, with the bromocriptine coming up, there is a tremendous interest in peripartum cardiomyopathy. If you diagnose it early and institute appropriate therapy with bromocriptine, there is a potential for reversal of this in early stages of heart failure. And our special interest have been with myocarditis, now increasingly recognized that this is a often overlooked cause of heart failure, which is potentially treatable. I'm sure all of you would have seen several lists of these endocrine causes and other causes of heart failure. Every one of them we have diagnosed and treated with gratifying results. One of the things I would like you to remember is, if you have a poor patient who lives on rice and fish, beriberi is very common in that subset. Rice is completely devoid of thiamine, and in addition, fish consumption increases the nutrition because it contains abundant thiaminase, and therefore these patients don't need to do any expensive test, just empirically give thiamine and see whether especially if the patient has a high output cardiac failure. Now, I would this is a pediatrician who came to us from Orissa with recurrent palpitations from 2004, moderate LV dysfunction, had an ICD, recurrent shocks, and was airlifted because of a possibility of transplant, heart failure with the EF of 22%, repeated heart failure hospitalization. Now, going through the history and other things, we realized that this patient has a hoarseness of voice and recurrent nerve palsy. He had abundant lymph nodes in subcarinal and parallel nodes, and a good uptake in the ventricular myocardium. Biopsy revealed plenty of non-caseating granuloma, which still showed active disease, and he was started on methylprednisolone.
Murugesh?
Hello? Yeah.
Can close. Since there is an interruption,
Yeah.
probably from net from his side is,
The interruption is there.
yeah. We'll take up the next.
Okay.
So now I request,
Hello.
hello, sir.
I'm sorry. I didn't realize I completely lost the
Yeah. You
connectivity.
can continue, sir. If it is.
Continue.
So this
Please continue.
patient is not an isolated example. The pediatrician I was mentioning, we continue to have this kind of cases over a period of time, that patients with either tuberculous myocarditis or sarcoid, and the diagnosis is improved when you go to the left ventricle and starting to do biopsies under echo guidance. And what is gratifying is a significant improvement there EF over a period of time. So we tend to forget that we are basically clinicians. Resting heart rate, early repolarization, QRS width, fractionation of QRS, pathological Q waves, ST segment shifts on ECG, QT interval and dispersion, T peak to T end interval. All these things from the ECG helps you to risk stratify a person who is at risk of sudden cardiac death, who is at risk of progression to heart failure, and you can titrate the therapy as may be. And this is a simple ECG of a patient who came with palpitation and heart failure. He was just going escalation of medical therapy. You can see pleomorphic PVCs. PVCs of two different morphologies, pleomorphism. You can see a fractionation of the QRS, poor R wave progression from V1 to V3, suggesting that he has got a septal scar. And again, diagnosis was confirmed later with a biopsy, and he was appropriately treated with reversal of heart failure. So simple ECG gives you a lot of clue as to what is going on instead of just passing it off as just a benign PVC. Now, I hope I'm audible and the slides are visible. Dr. Murugesh?
Slides are not visible.
I'm sorry.
The slides are not visible. Hello?
Someone has muted me or...
No. No,
You are.
audio is there, sir. Audio is there. We are able to hear you, but slides are not visible.
I really apologize for this.
Now they are visible.
Yes, it's coming.
Yeah, come.
So this is the electrocardiogram that I showed you of a person with heart failure and PVC. He was just escalated on medical therapy, loaded on amiodarone, and recommended an ICD. You don't realize that this person is losing his R waves. This is called pleomorphic PVCs, where there is more than one morphology of PVC. It suggests that there could be an active inflammation in this patient, and he was biopsied, confirmed to have granulomatous myocarditis, treated, and there is a reversal of both LV function and PVC. The other thing we would like to realize is patients, when they have concomitant renal dysfunction, when you put them on hemodialysis, it worsens the cardiac function. So there are something called as patients, they'll be all right, but thinking that you can clear the salt and water load, you put them on hemodialysis, their cardiac dysfunction worsens. We find that peritoneal dialysis is much better in that subset of patients. And correction of anemia, all of you are aware that these patients will require parenteral iron, and addressing the cause of anemia and treating it is important. Now, hepatic congestion, dysfunction, ascites, you need to take these things a little more seriously. If you have muscle wasting, and common things are thenar wasting, mesenteric wasting in these patients, they are terminal cases, don't have to keep on escalating therapy. You need to have a very low threshold for referring them to transplant or LVAD, as the case may be. So when they develop this kind of a problem, they have a leaky gut syndrome and they present with fever, low-grade constitutional syndrome. It's not due to infection, but because there is an upregulation of cytokines in them. And a significant percentage of them have sleep-disordered breathing, and correction of which will improve. Now, you may think it's paradoxical This is who had undergone a bypass surgery in Chennai and then had significant heart failure, was referred for CRTD with a pulse rate of 90, blood pressure was there, JVP was elevated, bilateral. This is the ECG, very wide QRS, and he was referred for 30%. By guidelines, this person requires a CRTD. All his grafts were closed, therefore someone recommended bypass surgery. Now, I would like to again, all that mattered was just examining the patient. This person had developed a mild clubbing, which was not supposed to be there in a pure heart failure. Evaluation revealed that all the Krebs, he was started on amiodarone for a PVC in his post-operative bypass, during bypass surgery. He had frequent PVCs. He was started on amiodarone. It was never stopped for 6 years. He came back to us with amiodarone-induced ILD, and because of ILD, he developed significant PAH, and he had a right heart failure. Everything due to ILD. I mean, it will be easy for me to plug in a CRTD, but both the patient and he will be a non-responder, saying that I did the best CRT, but patient didn't improve. We are barking at the wrong tree. These things are, I mean, that's why I put up the first thing is pause and see, is this really heart failure? Is this something else which is responsible for congestion, for his crepitations? And elevated JVP can all be because of something else in an occasional case. So we are moving towards more, I mean, I'm glad Dr. Javli presented this true picture of the robotic surgery and so on and so forth. We are just flooded with, but please understand that's not the answer to the problem. Careful evaluation, titrating this, and doing what is right for the long way in terms of improvement of the outcome. And to all physicians, please understand, I'm sure you would have been showed this slide from NEJM time and again. This is from SPRINT trial. 8,000 patients, 4,600 and 4,600, just maintaining a target blood pressure of 120 had a 50%, 40% reduction in progression of heart failure. You could prevent heart failure in 40% of these patients if you titrate and maintain their blood pressure at optimal levels. So the real heroes in medicine are the people who silently control all these things in terms of choice of appropriate therapy, risk factors. The epidemic heart failure can be prevented by appropriate treatment of the simple risk factors, because as a country, we cannot afford to have very expensive therapies for simple failure to treat inadequate diabetes and hypertension and landing up with ischemic heart failure, as the case may be. So the true heroes of medicine are you people who are taking this challenge, patients with metabolic disease and obesity, and modifying the risk factors, not only to prevent cardiovascular disease, but also to prevent worsening of renal function and ending up in dialysis in a vast majority of these patients. So careful clinical evaluation of patients with heart failure helps to identify several underlying systemic causes of heart failure. It has significant implications on both prognosis and treatment. And I would like to thank you for the kind invitation and the opportunity. And I profusely apologize for the glitches in audiovisual transmission. Thank you very much.
Thank you, sir. Thank you for a wonderful journey of various etiologies, pharmacodynamics, and giving excellent examples. We really loved your talk, and it has got a lot of clinical significance for the physicians here too. So questions can be taken up later on after the panel discussion. So over to Dr. Sangram Biradar for the next session of panel discussion.
Dr. Narasimhan, sir. Now we move on to the panel discussion. I request Dr. P.C. Manoria, sir, to conduct the panel discussion with all the panelists.
Sure, you enjoyed the flashes of expertise during all three discourses of legendary speakers. Dr. Mulsari, first question is, what is the best way to rule out STEMI? Time and conditions are confronted with patients of acute chest pain. Their initial electrocardiogram is normal. Initial serum markers may be normal. So under such a situation, what is your advice? How to do best to rule out STEMI? Dr. Mulsari.
I think the most important thing is a clinical history. If the patient has a classic history of chest pain, which is retrosternal or radiating to the arm, which is like a pressure on the chest, whatever may be the EKG, the enzymes may be too early. It is important to keep that patient there and repeat the EKGs, repeat the enzymes, because you will miss an MI by looking at the first ECG and saying that's normal and your enzymes may be too early to go up. So I think clinical history should be taken the most important predictor of STEMI. And I think that we should not. You may not lyse the patient till you get an ST elevation or whatever, but you will have to keep the patient there to check the EKG and then rule out an enzyme later.
Dr. Narasimhan, currently we categorize heart failure the ejection fraction, but now we know GLS detects LV systolic dysfunction even in the subclinical phase, and patients of HFpEF 20 to 25% may have diminished GLS. So what is your viewpoint? Has time come to categorize heart failure on the basis of GLS rather than ejection fraction? Dr. Narasimhan,
point that was brought up, because we are now understanding that EF may look normal because you have done a very good unloading of his ventricle. For example, a good dose of afterload reduction and everything, the EF may look normal. However, this patient's myocardium is still dysfunctional and that can be picked up by GLS. This is especially important in picking up subclinical cases. For example, a patient with family history of dilated cardiomyopathy, brother or sister comes, EF looks normal, but very early you can see that the GLS is abnormal. So very right, these patients are actually patients with HFrEF who are still having preserved ventricular function. The phenotype is different.
Dr. Jowli, there has been tremendous advances in bypass surgery. So which subset of patients of coronary artery disease who requires vascularization at the present state of time, CABG should be preferred in preference to PCI?
I think all the severe triple vessel disease, one can argue on this feasibility for PCI, where I can put 3-4 stents easily. But I think if there is a debate, go by the syntax scoring. But I think all the triple vessel disease, one should do PCIs. Lima, I mean the left main, if it's a distal disease, little complex disease, better not err on that. If it's a body, mouth, then that's a good indication for PCI.
Dr. Mulsari, in STEMI, our aim is not only to decrease ischemic risk, but also to minimize the bleeding risk. So what are various ways in you assess the bleeding risk, and what is your criteria for labeling a patient as a high bleeding risk?
So there are various ways. One is clinical. There are some scores which are available for assessing risk of bleeding versus ischemia. We have the precise DAPT score, the DAPT score for antiplatelet and anticoagulant therapy. You have the bleeding risk scores, which are HBR risk scores, which are available. But all of this, put it in a bucket, that the issue problem is that the people who have the highest bleeding risk are also the patients who have the highest ischemic risk. So unfortunately, the guy who needs the strongest antiplatelets for his ischemia are likely to be the patients who will also bleed. So the problem is there. So it's a sort of a difficult decision to make. But I use a clinical trick that if my patient is at a high ischemic risk and I'm say doing a PCI on that patient, the maximum ischemic risk is on the first couple of days. And then the bleeding risk takes over. After 30 days, the bleeding risk comes down. So if a patient has to bleed from his stomach or wherever it is, it happens usually in the first 30 days of the antiplatelet therapy. So after the first 30 days, then the ischemic and bleeding risk are almost running parallel. It doesn't go up and down. And then you can make a decision. So the first 30 days is where you need to keep a watch on everything. And then after that, you can make a decision. Okay, if he's a high ischemic risk, I can continue the dual antiplatelets for much longer. If it's a high bleeding risk, then I withdraw the second antiplatelet.
Do you think the bleeding risk should be periodically assessed, or people forget about it?
Yes, it's a dynamic process. And I think that we should never look at bleeding risk or ischemic risk at one point of time, because we have to keep on assessing with time and with treatment. And patients will present to you at some point of time, and then you have to make a decision that this is not good enough for ischemia or good enough for bleeding and make your decision and change it around.
Dr. Nirmal Narasimhan, I want your some takeaway for physicians regarding biomarkers used in heart failure. Your lecture was excellent. So some biomarkers when the physician should use, what is the limitation, what is the usefulness in the spectrum of heart failure?
Okay. So when we have a patient where the diagnosis is uncertain, you have a person what looks like a febrile illness, has a patch in the lung, he has a EF of 40%, you're not sure whether it's heart failure or not, we tend to use BNP as a very important marker, because if BNP is near normal, his syndrome is not due to heart failure, his symptom is not due to heart failure. And NT-proBNP is also used as a prognostic marker because despite optimal medical therapy, the patient's NT-proBNP remains elevated, then we would strongly push for an ICD or a device in him. Because in India, you can't be giving an ICD for every single patient and for a primary prevention. Whereas if you have a QT that is prolonged and NT-proBNP that is abnormal, we strongly recommend a device. Third thing is simple clinical markers like creatinine and dilutional hyponatremia. So if you have a person with dilutional hyponatremia, despite optimal medical therapy, then there is a very severe renin activation and has got a very progressive course of heart failure. And creatinine and rising creatinine is not again a good combination, especially if they have a person with right heart failure. So these are simple clinical markers. There are ever increasing clinical markers, but these are practical. But if I may, I'll just would like to ask one question to both Dr. Javli as well as this. See, unlike an angioplasty, the surgical, we all agree that it's very useful. We would like to see a complete revascularization. But the surgical results are so variable from place to place. Yes, there is a variability in angioplasty, but I think the surgical results are highly variable. So that is the main reasons why a particular center, if you have a surgeon where you watch the results, we'll be more than happy to send a person for surgery if there isn't a result. So what is your take on this?
Simon, you're absolutely right. That is why while doing analysis, meta-analysis, the problem in surgical papers is the biggest variable is the surgeon himself. And so that is something which we have to live with. But the paradox is, if a surgeon is good, automatically the cardiology department becomes very aggressive. So that's the paradox.
The other thing is, if I have a person, in order to address this thing, Dr. Manoria had asked, whenever I have a person who has already bled, who has got ecchymosis, frail person, and he needs multiple stenting, I have a low threshold for referring for surgery. Because you are looking at a 70-year-old person who will need a gallbladder surgery, who will need hernia surgery. So whenever I think the bleeding risk is high, and that makes it easier for me to decide between surgery and angioplasty. Of course, unless it's a single vessel disease or two vessel disease, which are focal lesions. That is my take, and I would like Ajit's opinion on it.
I agree, Narasimhan. I think we always have to take patients. See, as Vivek said, most of the centers which have good surgeons will have good cath lab intervention with focal. They could compete. And many of our centers like Narasimhan, yours and Vivek Center would have excellent cardiologists too. So I think that's a good thing to have, because I think it helps you to make a group team approach. And most centers like ours will have equal number of cardiac surgeries as compared to PCI. So I think in the end of the day, the importance of the patient being in the center of the focus and not be trying to do something to benefit either the procedure or your pocket would make the big difference in outcomes to patients, and that brings in more patients. So I think that this is a key note that we need to take. But if we think that, okay, this cardiac surgery is going to be beneficial overall, then I think we should take, and I agree with Vivek, triple vessel disease, especially with a distal left main involvement, should go to surgery, especially if you're diabetic. You should not undergo PCI.
Dr. Vivek, I want to say a couple of things where Narasimhan's that case example is concerned. If this patient has not got a good indication for PCI, he will come back for surgery, which will be a big problem. Secondly, today we have very smart hematology departments. We can study his hematology profile. And if he's a bleeder, he will bleed badly with the dual antiplatelets. And today, most of these things can be handled very well. And if he has cholecystectomy to be done, hernia to be done, we have almost a history of 2,000 cases where all these things can be racked back together at the same time in the same anesthesia, which makes it very patient friendly. Single time recovery, the money wise, the family torture wise, everything becomes simple and is really not as morbid as once upon a time we thought. So this is our practice today, but I would involve the hematologist. And if you think that he is a bleeder, then he is also a high risk for the dual antiplatelets. Most of the patients which we think are bleeders, surgically, they are really not.
Dr. Narasimhan, when do you prefer BNP and when do you prefer anti-BroNP, or they are exchangeable?
So if you're planning to start a person, the half-life of BNP is slightly shorter. And secondly, the sacubitril valsartan affects the BNP, but not anti-proBNP. So if you're planning to start a person on sacubitril valsartan, I would like to start a baseline, get a baseline anti-proBNP so that that can be used to follow it up.
I think that is a very important key message because ARNI is being increasingly used. Dr. Vivek, do you routinely look for myocardial viability in post-MI patients being taken up for CABG? If so, what is your preferred modality of choice for looking at viability?
I do only viability study to decide that I don't have to do operations. If I think that there is a tight reproducer disease, the distals are not bad, I think it's a waste of money and also adding more confusion. I straight away go and do the bypasses. Where the vessels are spidery, where the ischemia by symptoms is not much, heart failure is more, I may have to rule out the possibility of revascularization. I will do a study, and then I think today the MRI has, if the operator is smart, has come out to be a very good tool. We have a couple of people in Doran who are quite smart and their reports are very reliable.
Dr. Ajit, despite our best efforts, sometimes we do have bleed in patients who are at high bleeding risk following a PCI. Now, what is your strategy for blood transfusion in these subset of patients?
Okay, I think the most important thing is how severe is the blood bleeding, and that is very important. So we have seen with surgery and with interventional cardiology that blood itself may be a risk in patients who have to be given blood. So it's very important that you don't simply transfuse because a 1 gram percent fell or your hemoglobin is 9 or 10 grams percent. You should never, transfuse a patient. I usually don't transfuse patients unless there's a major drop, say 5 gram percent plus, and the hemoglobin is less than 7. Then I sort of look at it and say, okay, now this guy needs bleeding, or there's an active bleeding. Hemoglobin may not drop, but if the bleeding is very active, I get the blood ready. So this is very important, that blood itself can be harmful to the patient. And we have seen in both cardiac surgery and interventional cardiology that by replacing blood, you may create more problems for patients than good for patients.
There's also data to suggest that blood transfusion may increase morbidity and mortality.
Definitely.
Maybe sometime 2 times, 3 times. Any specific reasons for this?
Well, I think the rheological characteristics of blood itself will increase the chance of the platelets being more sticky. Number 2, if you unnecessarily give heme, that polycythemia itself creates problems. There are a lot of rheological factors which are not based on the blood and platelets alone, and especially the coagulation cascades may get activated. And we have seen both with surgery and with interventional cardiology that stents get thrombosed or bypasses get blocked or something else happens to patients after blood transfusion. So blood transfusion is not safe and should not be unnecessarily used when bleeding is not much.
And also this practice of giving 1 pint of packed cells or 2 pints of packed cells is absurd, because those fragility indexes are very low. It hardly raises the hemoglobin anyway, but it will add TRALI, it will add all damages. So, and the transfusion trigger can be really brought down lower. We have brought our transfusion trigger in surgery to between 7.5 to 8 or 7.5. So we can actually have patients with most of the patients. And 1 or 2 pints is really meaningless.
Dr. Mulsari, there has been some data on monoclonal antibodies to ticagrelor. So some comments in future, do you think we will have an antidote for the bleeding with ticagrelor?
Well, I think most of these newer antiplatelets and anticoagulants, the NOACs, have got now monoclonal antibodies coming in. And the problem with these are, even if, for example, the commonest monoclonal antibody which we have in this country is dabigatran. But from my personal experience, when the patient bleeds with dabigatran, you don't get the monoclonal antibody. And you're hunting around for that, and we are, and they can't keep it in your shelf because you don't bleed that many times. So just keeping it on your shelf doesn't make sense. So all the time this problem that you either have the monoclonal antibody not available, or the monoclonal antibody is too expensive for the patient. So most of these monoclonal antibodies for most of these drugs are a bit theoretical at this point of time. And I think at the end of the day, once a patient bleeds with these newer drugs, you had it. And you will have to just bide your time and replace whatever you can before you can slow it down.
Dr. Narasimhan, ECHO, all of us know, is a very useful modality for initial evaluation of patients of heart failure. But we know MRI is very useful. So what are subset patients of heart failure where you like to recommend MRI, or do you recommend in all cases of heart failure?
So if there's a clear etiology for heart failure, severe MRTR or valvular heart disease, ischemic heart disease, I don't have to do an MRI. If a patient has preserved wall thickness, there are not big Q waves on the ECG, we think the whole area is viable, we send them for surgery. But where the MRI becomes very useful is in patients with non-ischemic cardiomyopathy. So we have realized that non-ischemic cardiomyopathy is not a single entity. There are varied things. One is inflammatory disorder, one is infiltrative disorder, and one is familial cardiomyopathy. What determines the poor outcome in these patients is the progression of fibrosis. So if we have non-ischemic cardiomyopathy without fibrosis, then we can just safely manage them with medical therapy. But if there's a lot of contrast enhancement, LGE, we have a lower threshold for referring this person either for a device therapy, or if it's advanced heart failure, list them for a transplant.
You had shown a very interesting case of granulomatous myocarditis. You can have tuberculosis or sarcoidosis. Does it happen that at times there's an overlap, and despite all investigations, you're not sure whether it is sarcoidosis or tuberculosis, even
Yes.
after biopsy? And what do you do under the circumstances?
It's a very real problem in our country because, in fact, one of the trigger for sarcoid is a dead mycobacterial bacteria. That is, when the mycobacterium is killed and the cell wall remains, it can trigger a sarcoid-like reaction. But as a clinician, I can't be foolhardy and say that this is a dead bacteria. You end up treating for, if there's a slightest doubt that there is an ongoing tuberculosis, even past or present, we cover them with anti-tuberculous therapy. The only caveat is when you give rifampicin, you need to double the dose of steroids because it gets actively degraded with rifampicin.
Dr. Jali, you had shown interesting cases of hybrid procedures. So can you just elaborate what subset of patient do you submit for hybrid procedures in your day-to-day practice?
Clearly, very poor healing patients who are not good for open surgery, or if they land up in CPB, and the other lesions are good for stenting. And the Lima LAD by minimally invasive is so straightforward and simple. It's a 60 minutes operation. So these are the patients we are on doing hybrid. And of course, the aortic aneurysms, where there is a arch aneurysm and the patient has got very different morbidities and elderly, we can very easily do the arch exclusion and do a hybrid procedure.
Dr. Malsari, in the current COVID era, the myocardium we know can be involved by several other processes. And when a patient of acute chest pain present to us, he may have ST depression, ST segment elevation, and serum markers will be elevated. So how do you really make a diagnosis of STEMI when a patient with chest pain in this COVID era presents to you?
I think this is a very big problem because there can be broadly 2 or 3 areas. One is a patient who has coronary artery disease, who in the present of any infection, just like flu can do it, any pneumococcus can do it, they rupture a plaque in the COVID era and they develop as a STEMI, and they come to you with coronary artery disease precipitated by infection and inflammation with the STEMI. That is one way. The second, the COVID itself can create vasculitis, which is pan-inflammatory over all vessel walls, including the coronary, the pulmonary circuit, and many of the other vasculature. And they can present with slow flow and what we call as a typical vascular inflammatory endothelial thrombosis in pan-vascular territories, which could present as a STEMI with ST elevation in the coronary. We don't see a plaque, but you may see no flow, slow flow, and nothing in the coronaries as such, but a slow flow in the microcirculation. And the third cause which in COVID can come is less often seen, but in severe COVID, you can present as myocarditis, which can present as a myocardial disorder. It is not a vascular disorder, in which the patients will come with, again, STT changes, which are myocarditis. Now, the most important thing is, whatever be the problem, the prognosis is much worse than the normal STEMI. That is the thing. And however you treat, whether you treat with thrombolysis or you treat it with primary PCI, the mortality is almost 5 to 10 times higher than what you would have with the normal STEMI scenario. So I think it's a very, very difficult scenario at times, and we've had an experience of more than 100 of these patients now in the last 6 months with various presentations. And, it's sometimes difficult to treat them. Neither there's a clear-cut, criteria how you treat them. If you do an angiogram, there are the associated issues with the angiogram, but at least you rule out the first part versus the second and third. If you lyse the patient, then if you're the second or third part, then you unnecessarily lyse the patient and the bleeding increases. And if you do a primary PCI in a COVID, we've had some of these unfortunate scenarios where the patient was COVID positive, ST elevation, anterior wall, my young guy. We took him up, the primary PCI took 20 minutes, but then the patient progressed on the COVID, got multiple patches in the lung, and got into serious trouble because of COVID. And we had to got into trouble because of COVID, not because of the STEMI. So all these are big problems in the COVID era, and nobody knows clearly how to do it. But generally, we are being more, less aggressive, and we're only taking the younger patients with ST elevation, MI, anterior wall for a primary PCI, or patients who fail lysis for PCI in that scenario. Others mostly lysis wait and do it.
Dr. Narasimhan, post-MI patient ejection fraction less than 35 is a guideline-based indication for ICD, but this cannot be applied to our country because of a lot of financial exchange. So how do you further stratify these patients? You also do MRI to see the burden of the scar. How do you further progress that this patient is more likely to utilize ICD in the long run rather than the other subset of patient which may not, because this is a very costly affair.
So one thing is we reassess this patient with the optimal medical therapy at the end of 6 weeks. So if you find at the end of, first of all, let us clarify, before 6 weeks, half the deaths, so-called sudden deaths are not arrhythmic. They are myocardial ruptures or re-eyes, and ICDs are not likely to improve in the first. That's why most of the trials have been negative. Now, after 6 weeks, you find that the EF has improved and progressively the volumes are coming down. Then he's a person who has got a favorable remodeling. This person's arrhythmic risk is likely to be low. On the other hand, if you have a person where the LV function remains low and you have certain clues like what I said, the QT interval is prolonged, the NT-proBNP is elevated, we tend to push this person for a possible ICD. Now, if the ICD patient cannot afford, we keep them for the first 6 months on a low dose amiodarone and a high dose of beta blocker with the MRAs, hoping for the best, but having counseled the family that the best option is to consider an ICD.
How often you use bilateral memory grafts and problems associated with, or what happens in the long run?
Selective on bilateral IMAs. Those patients who are insulin dependent diabetic, their bone doesn't look very good. We don't venture on that, because if you look at the ARTS trial, the radial artery has done extremely well, and those old the preconceived ideas about radial arteries were wrong. We have been using radial artery for the last 22 years and we are pretty good with that. And so I have a very low trigger to use a radial artery instead of bilateral IMA. About 15% is bilateral IMA, and most of the others it is supplemented with radial, but we try to give a second arterial graft if it is possible.
Dr. Mulsari, how long you gave DAPT after PCI in a STEMI patient, and when you de-escalate from a dual therapy to monotherapy? Antiplatelets.
So I think there are in general, a dual antiplatelet therapy for ACS was 1 year, but that has now changed. And the newer drugs, especially the newer trials with the newer drugs, especially in the high bleeding risk patients, like the clear-cut, the TICOS trials and ticagrelor DM trials and many of the Twilight trials have shown clearly that in patients even with ACS and even STEMI, you can de-escalate the therapy at 3 months. And in high-risk patients, very high-risk patients, like in extremely elderly people, you can even de-escalate it at 1 month and remove aspirin and continue the other antiplatelet. So I think the dual antiplatelets are coming lower and lower in terms of times. But there is also a funny thing that patients, there are trials which have shown that, you know, after 1 year, especially with ticagrelor, the Pegasus-TIMI showed that you get a benefit of it. So there's a confusion about these things. I think you have to reevaluate them according to their bleeding risks and the overall risk and then decide.
Dr. Narasimhan, all of us know HFpREF is associated with a very high morbidity and mortality, but now we have 4 sets of drugs, beta blockers, ACE, ARB, oblique ARNI, MRAs, and the SGLT2 inhibitors, dapagliflozin. Should all these 4 patients be utilized in all patients of heart failure? What is your viewpoint on this?
So the first thing is, depending on, I mean, if we put all these things to a person, the cost goes up significantly. Patient should be able to afford it. So if you have a person who has been treated with beta blockers or ACE inhibitors, and he has got a very favorable remodeling, and the patient's NT-proBNP has nearly normalized, then I don't really change much in these patients, especially if he has a device. On the other hand, there are persons where cost is no problem. Instead of ACE or ARB, straight away we start sacubitril, valsartan, beta blocker. The decision to add DAPA depends on things. Number one, I still believe that the non-diabetics, diabetes is not a binary condition, yes or no, because there is a continual spectrum of person with insulin resistance. Persons who were non-diabetics in the DAPA-HF probably had a significant worsening of their insulin resistance, either because of diuretics or heart failure syndrome itself. So in these kind of patients, I would prefer to add DAPA. So the indirect evidence, high triglyceride, low HDL, high uric acid patients, metabolic syndrome, but normal blood sugar. These patients, I may still introduce DAPA or one of these SGLT2 inhibitors. All the others, that will probably be the lowest one, because now the next vericiguat is coming. We try to introduce that for a person with significant PAH, but normally decompressed ventricular.
In a non-diabetic patient who's on ACE inhibitors and beta blockers, he is little worsening. So which drug will you like to add first? ARNI, SGLT2 inhibitor, or both, and the reasons thereof?
Okay, this is a difficult question. So if a person has diabetic with vascular disease, and you find that LV filling pressures are still high, you've checked the echo and it shows a restrictive pattern and the estimated LA pressure is 25, then you get straight a tremendous benefit with SGL2. So if you find that the blood pressure, you have reached the maximum doses of SGL2 and the patient is still not doing well, you may add DAPA, especially if the patient has got, say, albumin creatinine ratio is high, which indicates that there is a diffuse, because that's a very important biomarker when we ask, is albuminuria in a person with diabetes. That indicates it's a global problem. I will have a lower threshold to introduce DAPA in such a patient.
Dr. Jolly, what is your strategy for DAPT after bypass surgery? When do you initiate? How long you continue?
The data on this issue is confusing and is not complete. Generally, we give them for 3 months and then switch on to aspirin. Talking about this multiple arterial grafts, a very important Indian cooperative study has been launched under the auspices and sponsorship of ICMR, a PREDICT study. It's 16 cooperating centers, 70 cases per center. Then the follow-up will go on till 2028. And this is prediction of mortality, the post-operative MIs, and repeat revascularization in diabetics after using more than one arterial grafts. It will be quite interesting to see the outcomes of this study. We are one of the participating members.
Dr. Mulsari, post PCI following STEMI, 1 year has passed. What would you suggest? Only aspirin, only ticagrelor, aspirin plus clopidogrel, or aspirin plus rivaroxaban? How do you decide the choice?
It's a tough question. So 1 year after ACS, you have various issues, So the data suggests that in general, if the patient is not a high risk STEMI, I would de-escalate antiplatelet therapy to a single antiplatelet. Your choice could be whatever you want, but there's no data that you can give aspirin or you need ticagrelor or you need prasugrel or you need clopidogrel. You can take one antiplatelet. The second issue is that do we need to prolong it? There's one trial called the Pegasus STEMI, which suggests in high risk STEMI patients, especially anti-Devol, after 1 year, you could use 60 milligram BD of ticagrelor or 90 milligram BD. 60 milligram is less bleeding than 90 milligram. But overall, it is more bleeding, but less ischemia as compared to single antiplatelet therapy. So again, you have to weigh the ischemic risk over the bleeding risk. Finally, do we need to de-escalate the whole therapy to aspirin plus, say, rivaroxaban? It comes a COMPASS trial. So we're at high risk for ischemia. Again, instead of continuing dual antiplatelet therapy, in a chronic stable group, you can, if you have peripheral vascular disease, you have CKD, you have other issues, you can have, instead of dual antiplatelet, you can add in chronic stable angina, rivaroxaban plus single antiplatelet. You can use that. But in general, we look at ischemic and bleeding risk and decide whether to continue 2 or 1 or a combination.
Dr. Narasimhan, how often you utilize CMR for quantitating scars? Say you are testing an ICD for a patient of cardiomyopathy, HCM or others, or even for coronary artery disease. How often you utilize, and is there any number cutoff for if the scarring is more than 10, 15, 20%, ICP may be strongly indicated? What are your viewpoints on this?
We tend to use this very often in persons with familial cardiomyopathy. So if you have a person with familial cardiomyopathy and the quantified scar is more than 10%, they have various cutoffs. Some people say 10, some people say 15%. I use 10%. The final word is not out. And second thing is more than the scar, you can see T2 weighted imaging showing a edema, myocardial edema. So all of us know from pathology, myocardial edema is going to become sooner or later. And there are indicators that persons with myocardial edema is a dynamic substrate and they have higher releases of MMPs and are at a higher risk. So it's not the scar alone, scar plus edema overall we quantify. And if 15%, I have a very low threshold for giving an IC.
Dr. Jolly, I like to have some awake CABG. You are known for it.
What we do is there are 2 subsets. One is myasthenia gravis and bad lungs, where FEV1 is poor. Bad myasthenia gravis, of course, if you don't give the general anesthesia paralysis, then the patient's mobility is very low because some people can get caught very badly. Secondly, the people with bad lungs, if you put endotracheal tube, you induce more bronchoria, you cause more bronchospasm, and there will be in our Indian situations of ICU, definitely various shades of infections. If you don't put a endotracheal tube, and these patients can be truly fast-tracked for physiotherapy. So these are the 2 indications where we are very firm on doing AVIC, and we get a lot of references on them. Other things one can argue.
Dr. Mulsari, in the COVID times, there's additional component of coagulopathy in these patients, even they are suffering from STEMI. So what advice you give on how do you treat this coagulopathy problem associated with COVID?
Okay, so there is a low molecular weight heparin is in general given to most patients of COVID in our hospital, especially those who have D-dimer which is high, RP which is high, because we know that these patients have a vascular reactivity which is high. So low molecular weight heparin is an important drug. The second issue is, do we use a NOAC or a warfarin after that on discharge, especially? That's a bit confusing. We don't have data still clearly whether after PCI in a STEMI patient, or after thrombolizing, do we need dual antiplatelets, or do we need a little bit more of anticoagulation, little month? There's a large trial which is coming with Valentin Fuster as a primary, which we are going to be part of, which may address this issue. But at this time, we should hold on with low molecular weight heparin, at least for the time of the COVID. Continue the aspirin and Plavix predominantly for the patients who get thrombolized, and aspirin with something else if you think they are having a high risk of stent thrombosis, if you are doing a stent in a primary PCI scenario or the pharmacoinvasive strategy. And I would just withdraw the low molecular weight heparin after a week and continue dual antiplatelet. Whether I should add an anticoagulant on top of it, the data will come out of this trial.
Dr. Narasimhan, all of us know this DAPA-HF trial has shown decreased hospitalization, decrease in CV mortality, decrease in all-cause mortality. So in future, what do you think? Will we change the criteria for resistant or refractory HEP? For example, when ARNI came, any patient of refractory heart failure, HFrEF will say, have you taken ARNI? If you've not taken ARNI, go and take ARNI, then come back. Now will you say, if you've taken SGLT2, if you've not taken, come and back? Will it do, and will it postpone the device therapy?
That's a very pertinent question.
Like LVAD.
And we have now understood a phenotype of diabetes as, again, insulinopenic, insulin resistance, GADA positive. So there are different shades. If you find that there is a significant interstitial matrix that is going up because of diabetes, these, I think, is an important mechanism by which DAPA acts or SGL2 acts. So if you have a person, MRI shows that there is increased T2 weighted imaging, diastolic function is impaired, or there is a proteinuria, albumin creatinine ratio is high, then straight away the first drug will be a DAPA. Whereas if you have a person who is insulin dependent diabetes, who didn't have any of these, I don't think that's probably a different ball game. We don't have sufficient evidence for that now.
Dr. Javli, what is the average mortality of a redo bypass surgery? Some takeaway on redo bypass surgery.
The fresh bypass surgery, it is the outcome and the mortalities are same. It all depends on the number of risk factors. So somebody with a chronic renal failure, with a bad elevated creatinine, poor lungs, bad LV, he will have a high mortality, but it will be the same whether fresh or redo. The redo has become fairly straightforward.
I think we had enough discussions, and I don't see any questions in the chat box. If anybody is want to ask any question, is welcome. You can directly ask or put a question in the chat box to any of the speakers. Dr. Brothers, you can, any chat box questions, you can direct it to these.
There are no chat box questions, sir. Since all the speakers have made it so clear, all presentations were so clear, they could not make questions out of the speakers. I think your moderation was quite fantastic. Anything from your end to be clarified for the audience?
I think you should have,
from your side.
we should have such
take-home message from your side.
Discussions more often. They are, we also learn a lot. Our concept got clarified.
Yeah. So what are your take-home messages from your side?
I think each speaker can
you summarize whole everything?
Each speaker can give the take-home message in their subjects.
Yeah. So start with the Dr.
I think
Ajit. Can you give up the
my take-home message is early reperfusion is more important than type of reperfusion. Thrombolysis is not given up, and I think it has come back very clearly in the COVID area, and we have realized how important that drug is. And it doesn't depend on what you have, whatever you have, and whatever the patient can afford, please give it early to the patient, but follow it up with an angiogram. Don't end your treatment with lysis. There's no more a scenario that lysis only because prognosis is poor, because you may have a problem later on because of the severity of coronary artery disease.
One more thing is our local cardiologists, they're all worried about the COVID intermittent era.
I think, I didn't show the paper. We just wrote a paper on fibrinolysis revisited in the COVID pandemic for the circulation, myself and Pedro. And we clearly showed that in the US, 50% of patients now get lysed. And this was a scenario which was not there 1 year ago. They were talking about 10%. So it is not about resources. The time also changes your strategy. So I think, which was the second second grade therapy for the third world country became first world therapy for the first world country just because of the pandemic. So I think which we learn with time.
Are we missing any of the genuine cases in this pandemic area?
Sorry, which cases?
Genuine intervention cases.
Yeah, well, I think so. The deference for primary PCI is a part of being trying to make yourself safe and the hospital safe. And I think this is a serious issue we have to worry about. So as a policy in my hospital, there is one cath lab which is COVID ready. So any young MI who has an antiretroviral comes with, or who is a lysis failure or is in shock, goes into the cath lab, whatever be his COVID reasons, we go in full precautions to go with the cath lab has got an open, suction so that, and we do treatment, we don't do the next case for 3 hours. So we have to do this because, you can't get a young MI, who comes 8 hours late, just waiting for lysis, which will not work in such a patient. We have to get this patient up and treat him aggressively. So I think we need to keep our minds and eyes open for all patients and treat patients according to what you feel is correct.
Thank you, sir. Sir, Dr. Narasimhan, sir, your take-home message for the...
Yeah, my thing is very simple. I think please attend to basic risk factors of heart failure. You can really prevent an epidemic. The answer lies in your hands in terms of adequate treatment of diabetes and hypertension. You can really prevent an epidemic of failure in this country.
Because in this COVID era, we are missing a lot of heart failure cases because of ARDS, this thing, mixed combinations. So any other protocols you have?
Using bars will be useful. Using the cytokine profile will be useful for these patients. They may have a combination because heart failure, any kind of increase in pulmonary afterload will worsen the right heart failure. So both may coexist. Clinical call you need to take.
Is there any difference in the IL-6 marker for heart failure versus COVID?
Yes, the level of IL-6 rise that you see is much higher in COVID because that's, in fact, these cytokines have been worked for several years, even in ARDS, and they have a very similar profile. And the IL-6, the rise that you see in heart failure is very, very mild, just about normal. Whereas when you see like 3-fold, 4-fold elevation of IL-6, it's not in heart failure. It's clearly an inflammatory syndrome that you're thinking. But please be aware, there's a lot of error in lab testing of IL-6. Transportation, everything delays can affect the true value. So before you pay attention to it, the pre-analytical errors need to be standardized.
Thank you, sir. So Dr. Vivek Jodi, sir,
invasive surgery is a wonderful new development. The post-operative recovery is impressively better. All the single valves, mitrals where the repair is not very complex, ASD, ASDPA, PVD, LA-myxomas, this can be a gold standard. For triple vessel coronary artery disease, one should temper the enthusiasm on insisting on this surgery. Robotic is not here yet, and this is my take-home message.
In this era of COVID, what is any protocols to be followed for surgery?
All the patients who come in, we advise them to finish the COVID before entering the hospital. We have our own in-house RT-PCR, which is available in 4 to 6 hours. We screen them and then we take them in, and the very next day we operate them. In the OT, we have now become, our expenditure has come down. We were very over-enthusiastic in the past. Good fitting N95 mask, well fitting, fresh, is the only real PPE. 98% everything will be taken care by that. In the beginning, when the patient is wheeled in, only anesthetic is inside. He's in a full PPE. That guy will intubate because he's going to suffer with droplets. Once he has established the airway, then the exhaust will go outside the theater where it is treated with UV light and out. Then the surgeon will come in, the juniors will open. There is another aerosol and droplet happening when the bone is being drilled and cut. The powders will come out. And after the whole thing is set, the senior will come. So the senior man who might be a little increased age, he is shielded. His appearance is kept less. He will come, he will do the surgery and go out. They will close and take the patient back. And the anesthesia and the ICU team, we have divided into two teams. One team will work, other team will take it easy for 1 week. Then they will come and relieve these people. By this, must have done cardiac and non-cardiac together in Bangalore Fortis, about 4,000 operations. Nobody, no patient developed any COVID infection from the hospital. No staff, surgeons and paraclinical developed from the patient any COVID infection. So, and our expenditure is about 10 to 15% more than a normal billing in the past.
That's fantastic, sir. Thank you. Dr. Manoria, sir, your
I think instead of
final
lectures, we
conclusion
should
and
have
take-home.
discussion and discussion. That is more fruitful and more, and everybody is awake when you are discussing. Rather than lectures, people will be more attentive. And I think I have seen that these discussions are much better, and most of the people like discussions and clarify their doubts. Otherwise, in a lecture, you cannot ask so many questions.
Okay, sir. There are no more questions because everything is clear and everybody is worried of COVID. That's why no questions are being asked by our people. Anyway, I thank on behalf of CSI, API, and all the organizers. I thank Dr. Ajit Mulasari for accepting our invitation in spite of a busy schedule. With your back-to-back programs in hand, still you could make it to join. Unfortunately, could not join physically. We'll see that next time we'll join physically. Dr. Manoria also could not come.
Bye-bye.
So many thanks for you. And one thing, I have received so many chat box that I will read one of that very informative virtual meeting on World Heart Day. Congratulations, Dr. PC Manoria, for super moderation. This is how the things are coming on. And I also thank Dr. Vivek Javadi for sparing his valuable time and joining with us and making all the aspects clear. Dr. Narasimhan sir, our own faculty, thank you once again for sparing your valuable and making all the things crystal clear. Thank you, all of you.
Good night.
See
Thank
you.
Bye-bye.
Physically some other time in some other conference.
Bye.
Thank you. Namaste. Thank you. Thanks, sir.